Okay, I don't know whether you came out with a lot of questions and ideas or things that you want to probe with the panelists, but I certainly did. And I'd like to take it, initially, some of my probes with them from some of those. Remember I said at the beginning, when there is a void, it gives you an opportunity for innovators or some other person to put something in it. And we've now seen some opportunities where people have put something in it. And some of the big voids that were implied in this were that being able to predict and prevent decline in patients in the ICU is actually part of, in a sense, the model that Stuart is working on a little bit. The issues of social justice and being able to provide health care in areas where it doesn't currently exist, part of what Erik was exploring. Renata, that we know we have this booming crisis of too many patients and too few healthcare workers. How can we start to create design and work processes, and what tools do we need to really manage to some of those issues? Thomas, talking about, I don't know whether you were in healthcare or observed healthcare during the 1970s and 80s, but we really had an opportunity to see the baby boomers. Baby boomers as a group influenced huge portions of the way we delivered obstetric care, and we are now seeing them move into geriatric care. Consumerism, and really managing to some of those expectations patients have of not being branded handicap by the hearing aid that you have to wear, or the cell phone that you have to use that has bigger buttons because your hands can't quite manage those teeny little buttons. And Chris, in the nature of kind of taking design and really starting to integrate it into the way we create processes, how we network ourselves to jumpstart learning, and all those kinds of things. So, panel, Stuart, for example, are you starting to look at kind of some of the powerful information that will come out of your system to be able to predict and prevent decline for patients? And I love the example he used. I'm a NICU nurse by former trade, former life, and so I recognized the patient right away. I recognized the 3 chest tubes that the patient had because of the pneumovacs that were sitting in the front. But 50% of that equipment I didn't recognize. That was terrifying to me. So there's lots of new equipment and new inputs that are coming into to patients. So
so detecting the conditions that need to be treated, detecting them early is really what this is all about. So the stuff that we've actually succeeded in doing so far is really more around the periphery, but the main goals are detecting things like cerebral edema, early onset of organ failure, early onset of lung injury, early onset of infection. So, we think, and my collaborator believes, if he sits there for 72 hours watching the patient and watching the monitor, he believes he can make much better treatment decisions than if he just meets with the nurses for 5 minutes every morning, which is the way it happens right now. So I also want to point out that the intensive care unit is just one example, right? You could take these same ideas and you could transfer them to chronic care, where you're actually following patients over months or years, and they're in the home, for example, or they're having occasional hospital visits. It's the ability to integrate data over time is really crucial to understanding what's happening with a person. So that's one of the main things that we're trying to do.
And that jumps me over to Renata, because one of the things is that 80% of care is actually delivered outside the hospital. So actually, how do you start to see some of your work start to translate into some of that out of hospital process?
Well, one thing, I've actually started to work with the VA and have these conversations with them because they have this data about continuity of care, and again, can we look at where care is administered, when it's administered, and what is needed, and kind of take this predictive type of modeling onto outside of the hospital. So yeah, so we're starting to look at that.
We had a question out in the audience. And do you give the ladies that are passing the microphone an opportunity, because I think you're recording, are you, Ravi? So they want to capture all the comments.
My question is actually, it's a theme that I noticed among all your works, is that you start with sort of raw data and you make sense of it in the hopes that it could be interpreted and used in a different way. And to a large degree, even with your work, Renata, it's synthesis and presentation at a level above which people actually have it. And Stuart, I think yours is a perfect example of that. I'm wondering of the implication of this and what you think of this. Clearly there's many PhD theses here on this topic, but there is this issue of cognitive overload in places like ICU units and hospitals and healthcare in general, where there's a tremendous amount of information that's essentially assaulting the people who work in those environments. And I realize that in many of these efforts you're reducing the signal-to-noise ratio, increasing the signal-to-noise ratio, but there's still a signal that needs to be paid attention to. What are your thoughts on that? And is it ever possible to sort of get away from that to some degree where it's a little bit more pleasant place to work? Or are we eventually working toward a place where the intelligence is sort of moving up layers from the actual raw data? And are there implications for propagating error that way?
I think so. Let me take that in two parts. So first of all, the overload is there in spades. I mean, if you've all seen pictures like Apollo 13, mission control. There's like 50 guys with steel rimmed glasses and short sleeve shirts sitting there looking at all this telemetry data from one rocket. Now that rocket is far simpler than a human body, and yet needs 50 guys to look at the data that's being generated from this rocket. Whereas, they have one nurse looking at 5 patients with all of this, and each patient has a dozen, 15 screens churning out data all the time. So the overload is ridiculous. And so what happens is all the data is ignored, by and large. So certainly you would like it to be the case that the data is actually processed more intelligently and summarized and made available in a form that a human being could actually make sense of and act on in a reasonable time frame. So part of the problem is just the business model. Nobody wants to feed their data to any kind of common display surface. Instead, they have their own proprietary data formats, their own proprietary displays, because they imagine fondly that somehow they're going to get a monopoly of the whole ICU if they keep this up. It seems insane to me. So it really would make sense that there be one display and that techniques of intelligent user interface design be applied so that the stuff that's on the display is what needs to be on there, and that will vary according to the circumstance. And it's easy for the nurse to drill down into the data, to look at past data and so on. This is not rocket science, to repeat the metaphor from before.
I think again, from a design perspective, it's pretty easy to design a complex system, but designing a simple system that kind of is complex is one of the hardest design challenges at all. So if the users say, hey, this looks simple, even though it has a lot of functionality underneath it, it's really a brilliant design. Whereas if you have these kind of systems with a lot of buttons and all the feature lists and stuff like that, then you're probably not at the final stage of your design. So creating a complex, simple design is one of the biggest challenges at all, also for healthcare.
We have a question over here.
I work for a relatively small healthcare system, 2 hospitals. Different workflows in the different hospitals. And every time we start talking about trying to take the time necessary to build models of workflow processes to try to improve these things, what we find out is it takes an incredible amount of time of our nurses, our nurse managers, our physicians, physician managers, and it really acts as a kind of impediment to building those models. The ICU discussion and the use of HL7 to make predictive forecasts about the consumption of resources in the hospital. Is this something that is going to require a lot of engineering input up front, or is it something to build these models, or is this something that is going to happen in a kind of an automated fashion so that suggestions about workflow improvements will fall out of effectively the data gathering process?
Stuart? Okay, I'll start. Ideally, we'd like to make it as automated as possible. And to address your point about the work of nurses doing up front, and industrial engineers are trained to do that, to go into a system and look at it and sort of have the tools. And I actually taught a systems engineering class for nurses this past summer. And when the nurses told me, she said, I'm expected to do this thing, but I don't have all these things, but I don't have the tools. And that's where I think an engineer, as kind of an observer, can come in and look at a system and analyze and quantize and model it. So that's what I think we can bring. And what we hope to do is have an automated way to generate these types of predictive systems, because you don't want to spend days and days sitting there with someone and talking about it. And I think that's kind of the beauty of mining the data that exists and is out there, is because that's specific to your institution, because that's the data from your institution. And I think one of the large issues in modeling and in simulation and queuing and all these things you hear is a lot of these models are not transferable, because they were built with they require a lot of data, a lot of input from one location, and then it's very difficult to transfer it to another. So that's why our idea is using these HL7 messages and coming up with a way to automatically create these models would solve some of this additional workload on the nurses and clinicians. So, I don't know, Stuart.
So for these models that we're using of human physiology, they are, in some sense, completely generic. So we're building a model of human physiology, and as long as you've got humans in the ICU, there shouldn't be a requirement to tailor it by hand for the particular patient circumstance. It is true that every patient is different, and the models have this built-in learning mechanism that will automatically estimate the parameters of the particular patient. So let's take something like blood volume. So that's part of the cardiovascular model, but there's no straightforward direct measure of blood volume available in the ICU. But the model can actually estimate that parameter from looking at the way the whole system is behaving. It can figure it out for that particular patient. So the models adapt themselves to the patient by looking at the data that's coming from the patient. And the only extra work that you need to do, and if you did this in a new hospital, would be if the hospital is using a new kind of sensor that was different from the ones that were described elsewhere, then you would need to build a model that characterizes that sensor. But that's, basically you would do that at the manufacturer level, not necessarily at the individual hospital level.
I'd like to add something. Can I add something?
Yes, please.
Sure. So you also mentioned that it's just a lot of work to perhaps do process engineering or mapping and understanding the full workflow, and I fully agree with that. On a very practical level, and this might be blasphemy for some people, it's less important to understand the very nature of your as-is model as it is to inspire and design for where you want to be. And so, for example, Kaiser, we have 4 hospital regions, we have 33 hospitals, and they are different, but they're also similar enough to design together. And so we're not interested in understanding every nuance of every workflow in every unit. However, we design together to understand where the workflows should be as a system, and then how do we move each of those individual units to that new standard, which we call a minimum set of specifications. So we're not trying to standardize, we're actually trying to create a minimum standard that people can at least meet, and hopefully we inspire them to continue innovating and designing to make it even better. So there's a way of getting around. I used to do process engineering, and it's very intensive, but there's a way to get around it, and we do that from a human-centered perspective, and going into the near present and the far future and designing for that rather than trying to understand all the mechanics of what's happening right now. So.
We had a question over here.
Some of you addressed it already, but could you comment a bit on how big a challenge it is to make users trust the technology before you start using a model for overbooking or a technology for emergency care? Is it trivial or big, and how do you overcome it?
Trusting the technology.
At least one of the experiences we have had is that if, for instance, you want to introduce something to doctors and nurses and stuff like that, involving them really early in the design process is a good way of giving them the feeling that this is not a product that a company is coming and trying to force them to use, but it's actually their own products they have developed through a number of workshops. So at least one answer would be to involve the user early on. So when you introduce a new device in a hospital setting, it's not something completely unfamiliar, but something they felt that we actually built this system.
Chris, how does that then translate into innovative processes? Because I think regularly it's, the kind of not invented here syndrome.
Yep.
And
same. We invite users every step of the way. In fact, the users are the ones who are the developers. We're temporarily turning them into designers. And so by marrying West Los Angeles with Hayward for several months, we can avoid the not in my backyard or not invented here syndrome. The other piece with processes that are a little bit more tricky than designing a tool or a technology is that a process or a service is mostly a behavior. And so to make these behaviors stick or these services be replicated over and over again, you also have to embed sustainability pieces into that. And so the way we do that is through metrics. And metrics aren't meant just for observation, they're meant for action. So when we deliver an innovative service, we marry that with a set of sustainability concepts and ideas that go along with it. So a lot of people don't like the whole Hawthorne effect where you toss something out there and then you're just affecting the system. Well, we try to capitalize on that. Great. How can we use that to our advantage? So our innovations are not just the behavior or just the cup or the technology. It's sustainability ideas that go along with it. And sustainability is forever. You have to keep doing it over and over again. That's why Big Macs taste good. 10 years ago, 20 years ago, 50 years ago. It's consistent.
Erik, let's take that then to the Congo, though.
Sure.
Because, with somebody there to support the kind of change process or the technology or the user, you may not have that. So that kind of has to be reliable, has to function the way it does, is kind of, has maybe a different threshold in the...
Yeah, I think that's absolutely true. I mean, it's, in the course of our project, we're having to build in a lot of field testing, build in a lot of input from the users so that, what we might design in our lab in Berkeley might not work at all in the conditions that we would take over there. Considerations of power consumption or power not being reliable or reagents not being able to be stored properly or shipping times, all these things that we would really take for granted. So yeah, I mean, I think we're going to have a much more sort of field-heavy and iterative design process than we would have here.
I was at the American Telemedicine Association meeting yesterday and the day before, and Lord Swenfen, who has a large foundation for funding connections between healthcare providers in third world countries and industrialized nations, connect to be able to give consults. There was a picture where somebody was taking a cell phone picture of an X-ray that they could then transmit to an expert in the United Kingdom. And so what other, given that cell phone is really seeming to be the pervasive platform, what other kind of innovations do you see kind of moving to the cell phone other than microscopy and some things?
Well, I think I've seen some other people talk about using the cell phone to be able to do tracking patients over time, doing the data entry in a way that that people are already familiar with using this technology, even if they're not comfortable with a lot of others. And so being able to have this sort of ready-made electronic patient record could be an easy application of the cell phone technology.
I mean,
Short comment before, and it's just, again, if you deploy technology and you want to deploy it in the homes of people, you really need to think about how to support it from the first moment on, because you just can't imagine how many things that can go wrong, even with simple technology, not being able to get a connection, not being able to do all these things, and especially with elderly, there's a lot of things to do to get the system working. So you really need to think about support from the first moment on. You design technology for the homes.
Yeah, the picture you showed of the the flowers on top of that. Have you created that notebook so it takes water and cold and things like that? There's a question over here.
Yeah, hi. This is a question to Chris, also to the panel as well. So you presented sort of the design for quality kind of methodology. I mean, you use different words, and so I'm familiar with that whole area. One of the things actually I think that needs work is, I think in your work you showed design for nurses' sort of satisfaction in some sense. But what about design for the patient? Because there's this whole philosophy of design for the consumer, or design for the patient, as the patient care is moving from the hospital to the homes and outside. Not many people have looked at the design at much more depth at the patient level.
Sure.
That means instead of having a bunch of physicians and nurses in your laboratory, let's say get patients inside and let them do the design of the insides of the hospital and the outside of the hospital. Is that being looked at? That's something that's more fascinating and it's hard to capture.
Yeah.
And that's something I think would open up new ideas.
Sure.
At the same time, in terms of information being shown to them and, whatever, those kind of things.
Absolutely. This was just one example. This was mostly a nursing-focused example, but we have patients and doctors and nurses on our design team. In fact, our project that we're currently working on right now is transitions from the hospital to the home, and our team, along with a couple other folks, have spent, I think, over 100 hours in our patients' homes, observing and interviewing them and really trying to understand. Clinicians have a very specific view of what they think clinically is happening, but when you get into someone's home and watch them navigate their medication bottles at 4 o'clock in the morning, you get a very, very different perspective. And then those same people who are creating all these workarounds to understand and use their medications in their home, we invite them to be a part of the design process and help us better create systems that will fit into their home lives. We do think that's where care is going, is into the home, so we're spending more and more time in people's homes. Yeah, absolutely. So it depends on the design challenge we're working on. So right now we're deeply in people's homes. Last year we were deeply in the hospital. It just depends on where we're at.
We also tried to do a workshop in the waiting area in the hospital, where we asked the patient, they could wait in kind of a non-workshop waiting area, or they could kind of join our workshop where we've kind of completely transformed the waiting area. We had provided food and kind of a cozy atmosphere and stuff like that, and use this to have a workshop with the patients and hearing their view both before entering a consultation and coming back again. So I think there's a lot of things to do to involve the patient in all these different kind of areas. And I think another key point about patients are that, especially with chronic patients, they are experts too. If you have a diabetes doctor, this doctor might have kind of the clinical expertise, but the patient has kind of the everyday expertise of how to manage the diabetes 24/7, and this kind of expertise you really need to bring into the loop as well.
But I think another aspect of that moving care to the home is not just the single patient that's managing their disease, but also the extended caregivers in the family. And so to count them in on part of that design really becomes important. I was part of a design group with Chris's group looking at private room NICUs. And, where the family, the patient that Stuart showed us so well, that little teeny infant in that crib, in that huge room with all the equipment around it. Well, the family's behind one of those pieces of equipment. And so So their experience and their ability to adjunct care, especially as we're moving into this decreased volume of caregivers and increased volume of care needers. Ravi, and then a question over here, and then a question in back. Okay, so you first, then Ravi, then back. We'll just make a swoop this way then.
No, there's so many opportunities to innovate in healthcare, and I'm just wondering, especially with Chris, being with Kaiser Permanente, how you prioritize what you decide to test, and even in the other academic settings, how you decide if it's solely based on funding, if there are committees looking at this. I'm from Kaiser in Southern California, and we have that same perspective that it's really difficult to choose what to do next and where to use your resources.
So is the question on how we decide to test, or what we decide to actually tackle? To tackle, okay. Well, early on, right now, there's a lot of low-hanging fruit that are pretty powerful. Like, it's hard to say no to medication administration. It's hard to say no to nurse communications. These things are just fundamentally broken, and those are easy to say, we're going to do that, and we'll take it on. We're now we have a few more low-hanging fruit that we can probably tackle, and then we'll start needing better mechanisms for prioritization. Right now, the way we do prioritize, though, is we're looking for problems that are big and universal. So we're not looking for a problem that one unit or one hospital has, but we want the problem for the whole industry. We want the problem that, and that multiple organizations would be willing to collaborate on, because we're also looking for universal design. So we don't want to tackle a singular problem. We also don't want to tackle something that would just provide a solution just for one or two people. So that's currently how we're prioritizing. We will come up with a better way of actually what is the thing, but right now we're still lucky. We're only 5 years old, so there's a lot of fruit out there.
So I just wanted to say, actually, it's sort of an answer to both this question and the previous question. So my answer to the previous question is a gift with purchase is usually a very great incentive. For this question, I think until you have a good picture of what's going on, you don't know what the big problems really are. And finding ways of collecting and displaying the data so that someone can actually see in a holistic way what's really happening. So, for example, Renata's, if you know how to read Petri net diagrams, then probably looking at Renata's diagram of how that whole hospital operation would be incredibly illuminating. So with our project, very early on, we developed a way to graphically display the entire medication history of an ICU patient, which, according to the ICU people, they had never ever seen before. What are the medications that they give a patient? And there are more than, for this one patient that we started with, there were more than 50 medications. It was 35 days. I think there were 14,000 drug administrations for this patient, about more than 200 infusions. So we were able to show all that basically in one screen, in a way that within 10 seconds they realized that whenever he was paralyzed, they stopped giving him pain medication. Why is that? Well, because when he's paralyzed, he can't express pain. So they realized that they're really traumatizing most of their patients by stopping the analgesics when the patients have paralytics. And that took literally 10 seconds after they saw the display. So if you can find a way of getting a holistic graphical display of what's happening in a system or in the care of a patient, then it's often obvious some of the things you can tackle.
Ravi, and then back at the back.
You may have just answered the question, but I'll ask it for the rest of the panel perhaps. What occurs to me is that in all of the approaches, there's varying levels of intelligence, and it's either distributed in the model. For example, Erik, the distributed model may be that the acquisition is distributed from the people who actually make the decisions, and in Stuart, yours might be is a question of where you actually embed the intelligence to be most actionable. But I'm really sort of wondering how you make that decision of embedding the intelligence in the process of care, and you know, in maybe computational ability in your case, Stuart, might be the biggest factor. I mean, how big of a computational footprint do you need to make this analysis in real time, or can it even be made in real time? And maybe, Chris, from your standpoint, if you're designing the healthcare process, the key is to get good care, but there's a series of decisions that need to be maintained in order to get that good care. So I imagine there's a point at which you try to engineer the intelligence so you get that. Mm-hmm. So in all your cases, what constrains that decision, and what helps you figure out where to put it?
I can start. So I think in our case, it's because the need is so immense, it's kind of how far down the chain can we make the appropriate decision? Like if we can get software on the phone to process something automatically, then and the alternative is having a healthcare worker there who's already overburdened, then it'd be great to get the software to process it automatically. But if it is something that requires more expert analysis, then moving that either to someone there in a easier to look at fashion maybe, or the way that we've been looking at it so far is moving it off site where that expertise is more abundant and people might have the bandwidth to be able to process that and meet that need.
I will try. So again, a lot of what we're coming up with is experience design and the feeling that we get when we interact with our healthcare systems. And at least right now, the way we measure that is through direct observation, which is a heck of a lot of work. And a lot of time commitment, especially as we scale these things up, because how do you pay attention all the time to the behaviors that are happening? So we try to do the minimal we need to do to understand where the process is. So for example, in KP MedWrite, there's 25 steps for KP MedWrite, which is actually pretty small compared to some of the processes that we've seen other nurses go through for their good medication administration. So we've tried to lean it down, make it easy, simple to understand. But of those 25, we feel there's 10 really compelling ones that must be administered properly. And so we do direct observation randomly throughout the month on all the units to see if these things are happening in the correct order. We don't have a way to track that, to automate that yet. I think that would be the next level of sophistication, but we're just not there yet.
I have a small comment too. I think it's also really important to see that humans and computers are good at very, very different things. So you should, again, in your intelligent system, make it distributed like you pointed out. So let the computers do the kind of task that the computers are pretty good at, and then keep involving humans in the loop in the cases where they actually have the strength and power. So it's not kind of like making it all intelligent or making it all human-centered, but kind of finding the best of both worlds.
And I think a little bit in this also is part of some of the observation requirements are getting people to buy into the actual behaviors that are going on either prior to the change or during the change or after the change. And it's to that sometimes you don't need a lot of data, you just need some acknowledgement that some of the issues exist.
Yeah, absolutely.
Okay, back in the back.
I'm just curious, are the panelists aware of the term black swans?
I'm sorry, I didn't hear.
I'm sorry, we didn't hear you.
Are you familiar with the term black swans?
Black swans. Can someone define? I don't think we use that term in this section.
Having a Palin moment.
Okay.
I don't know.
It's back in the 1900s when they were developing a biological system in England. They assumed that swans were white. And then all of a sudden they went to Australia and they found black swans. So they had to go back and rechange their system. And I'm curious, when the systems that you're developing, how do you handle when you run across black swans? The reason I'm asking is I'm classified as a quadriplegic, even though I don't feel a lot of parameters of being a quadriplegic. So when I go into most medical systems, they don't know how to handle me because I don't fit neatly in any box.
So I can try to give you an answer. I don't know if it's exactly what you're asking, but again, I think to take a concrete example, we're designing something for the waiting area in the emergency department, and our kind of hypothesis was that all the patients in the waiting area wanted to know how long they had to wait until they were seen by a doctor. That was kind of like all the swans are white. Then we showed it to the nurses down at the emergency units, and they were kind of terrified. They were kind of seeing a riot if this system were put into use, because what the patient wanted was they wanted to know the exact waiting time if it was only going down, if it at some point were going up, they will kind of come right to the nurse and complain about it. Because even though there were kind of a family with a small child and it was late in the evening or something like that, if there were a person that has been waking for 2 hours or something like that, there was no kind of respect for changing kind of the waiting order or something like that. And this was an example where we were sent back again and saying, this is just not good enough. The world is not like you think it is. You have to re-evaluate your design based on this experience.
Any other questions? Well, join me in thanking the panel for this lively discussion.
Please thank me in thanking our moderator, Barbara Harvath. So we're at the end of our session, and this is essentially I'll make this a very brief wrap-up and closing. The intent of this whole conference was to look at ways in which we can improve the service of healthcare. And I think we've managed to do that pretty well. I've actually had a few requests to do this again, which, quite frankly, I don't want to think about for a little while. But I think we'll certainly consider it. We've looked at sort of technological means that act as a platform for service. In the workshop, we looked at is there such a thing as a laboratory for services? We have product labs, but can we in fact have a service laboratory? We also considered the actual ways and techniques you can improve it, from the human and behavioral all the way down to the computational. So it makes for a very interesting set. Sadly, there are many people here that we would love to have had that couldn't make it, and I think maybe with some advanced planning we might be able to do that. I'd like to thank you all for coming, and we're officially adjourned, and you're certainly welcome to stay for a short reception outside and again on the terrace and have some discussions with our speakers and amongst yourselves. So thank you very much, and please look for the slides and the presentations on YouTube and the CITRIS channel.